Hyponatremia. Sound scary, a big topic, complicated. We don't think it's going to turn up in our exams. Unfortunately, no. It's a common area of questions in FRCEM final OSCE and MRCEM OSCE, and a common area of question in SBA exams. But don't worry. First of all, I'm Dr. Mohanad Abdelmajid. I'm one of FRCEM Academy course instructor, and today I will try my best to summarize the management of hyponatremia in ED setting. Let's just start with the definitions. The definition of hyponatremia, that meaning the serum sodium in our blood is less than 135 millimole per liter. Then let's just highlight on the classification. So the classification of hyponatremia, can be classified based on the severity to mild, moderate, severe. Mild if the serum 130 to 135, moderate if the serum was 125 to 129, severe if the serum sodium was less than 129. We can also classify it based on the onset of the hyponatremia, when it's happened. If it's happened in less than 48 hours, this is acute. If it's more than 48 hours, this is chronic. And it's difficult to determine if it was a chronic or acute. So the general rule here, most of the cases are chronic unless there was obvious reason. The common obvious reason for acute will be recent surgery, for example, the patient post-ops. And also we can classify it based on the serum osmolarity to hyperosmolar hyponatremia, pseudo hyponatremia or isotonic hyponatremia, and the third type, which is the most common one and the most important one, which is hypotonic or true hyponatremia. The hypotonic hyponatremia, we can classify it in 3 types, and I will try to give an example for each type of them. So the first one, which is hypovolemic hyponatremia, the common cause of it, thiazide, primary adrenal insufficiency, extensive burn, bowel obstruction, pancreatitis, sepsis. The second one, hypervolemic hyponatremia, the common type for them, the common causes will be congestive heart failure, liver disease, kidney disease. The third type, euvolemic hyponatremia, and the most common causes will be also drug like thiazide, SSRI, and hypothyroidism and sciatica, which is endocrine abnormality. I hope it's clear so far. So let's go to the clinical feature of hyponatremia, what you should expect it. So just keep in your mind, and this is general rule, the most of the people who are suffering from hyponatremia are asymptomatic. Especially if the hyponatremia was a mild hyponatremia. So most of the patient don't have any symptoms or asymptomatic. So when the symptoms are present, it will be, to be honest, related to the severity and the rate of the onset. I mean, if it was a moderate, severe, or it was acute hyponatremia, they will have some symptoms. So the symptoms will be a vague symptom like headache, nausea, vomiting, muscle cramp, lethargy, restlessness, disorientations. And one of the severe symptom will be the patient will come with a low GCS, will come with a seizure. So consider hyponatremia, especially in seizure, please. And also I want you to remember something. The chronic mild hyponatremia can lead to gait instability, can lead to fall, can lead to deficit in concentration and cognitive function of the patients. So remember, especially in UK, we are seeing in the ED a lot of elderly who's coming with a fall, or the family concerning that my dad or my mom, her cognitive function is not like before. Okay, so maybe you will keep your mind, this is dementia, this is stroke. Yeah, it could be, but also hyponatremia, one of the reason. Even if it's mild, it could be the reason for their fall, for their the cognitive behavior dysfunctions, or to decrease their concentrations, or to their gait instability. Okay, let's go to the management now. Okay, so the management of hyponatremia in ED, like any other ED patients, you should start with the A, B, C, D, E, especially if there is a seizure or coma, which is the most severe symptom of hyponatremia. So if the patient came with a low GCS, seizure, start with A, B, C, D, E, stabilize the patient, then treat the seizure and treat the low GCS. So the low GCS, keep that in your mind, or coma, or the seizure, the treatment, it's a top emergency. So the treatment of choice will be, the first line will be 3% hypertonic saline, the dose 100 to 150 ml, should be given within 5 to 10 minutes. The first line, 3% hypertonic saline, 100 to 150 ml within 5 to 10 minutes. If there is no improve, you can give another bolus. Okay. If you don't have in your department a 3% hypertonic saline, the second line will be IV sodium bicarb. The same dose will be, which is 100 to 150 sodium bicarb over 5 minutes. Okay. Let's say there was no a serious symptom, or no severe symptom like seizure or coma. Okay, just the patients came with disorientations, or nausea, vomiting, muscle cramp, or fall, and you found that the sodium is low. So what I'm gonna do? Okay, first of all, you have to assess the volume status to determine if it was hypovolemic, euvolemic, or hypervolemic hyponatremia. How are we gonna assess that? So it's a simple scale. You have to take a proper history, okay, past medical history, the drug history, if there was a vomiting, nausea, symptom of sepsis or infections, assess that carefully. And during your examinations, definitely you will assess the heart rate, the blood pressure, to find if there is a sign of dehydrations, if the GVP was high, which could be a sign of congestive heart failure. Also, if there is edema or no, if there is an postural drop or no. And we can also do bedside ultrasound to see if the patient dehydrated or no, if the fluid volume is high or low. Okay, so if we found that the patient's hypovolemic hyponatremia, okay, please correct the hypovolemia as soon as possible. And the fluid of choice, the best fluid is Hartmann solution, or some people call it Ringer lactate. Okay, why? Why the sodium, or why the Hartmann solution it's superior to this normal saline? Because I believe it will slower raise the sodium. So the risk of the osmotic demyelination syndrome, it's less when you're giving Hartmann solution or linger lactate. And there is many studies prove that. However, it's worth to mention here, the NICE guideline still advising to or recommended to give normal saline. Okay, so what is the dose? You will give fluid a slow or multiple bolus. So you will start with 250 to 500 ml. Okay, you will give the first bolus. If the blood pressure improve and the hypovolemic status fixed, that's fine. If it still need a more dose, you can give another bolus. And it's guided definitely by the blood pressure. So when the blood pressure and the heart rate improve, that meaning you manage the hypovolemia. And please hold any further corrections. Since you fix the hypovolemia, hold any further corrections by doing water restrictions and hold also the diuretics. What if the fluid status or the patient's or the condition was euvolemic hyponatremia? Euvolemic hyponatremia, the general rule, doesn't need any specific treatment in ED. And our aim will be to prevent any further drop in the serum sodium by do fluid restrictions. What if the condition was hypervolemic hyponatremia? Also, there is no specific treatment in ED, apart from fluid restrictions. And in some cases, if the patient was symptomatic hypervolemic, got some hypervolemic symptoms like fluid overload due to congestive heart failure, we can give IV furosemide. The last thing that I want you to remember and keep it in your mind, we should not correct more than 6 to 8 millimole of the sodium within the first 24 hours. The general rule here, we should not correct more than the 6 to 8 millimole of the serum sodium in the first 24 hours. Sorry, I have mentioned earlier the severe hyponatremia, it's less than 129, and I'm sorry for that. Actually, the severe hyponatremia is less than 125. Severe hyponatremia is less than 125. Thank you and good luck to everyone again.